Hi there, this is Marielle Conception, your host of the My DPC Story podcast. Have you or someone you care about ever been burned by the U.S. healthcare system? If so, you are listening to the right video, because if you are listening, chances are the answer is yes. But the U.S. spends so much on healthcare. Why are so many Americans affected personally and especially financially by the healthcare system? Shouldn't that mean we have better healthcare access and treatment options? Shouldn't it be easy for us to be able to see our doctor when we need to instead of turning to the ER or urgent care? Historically, it's been seemingly impossible to answer these questions. But now that is changing through the direct primary care movement. This video that you have tuned into will bring you into the world of direct primary care and show you how physicians all over the country are changing the way they practice so patients from all backgrounds get the high quality care they need and deserve, which makes for both happy patients and physicians. Learn even more by subscribing to the My DPC Story YouTube channel. Find us on all major podcast platforms. Find us on socials at My DPC Story and at mydpcstory.com. There you can find resources including how to find a DPC doctor near you, conferences about DPC, DPC startup guides and advice, a store with DPC swag, and even a mapper showing where podcast guests are practicing. Thanks for tuning in to hear about this powerful movement. Now, on to the episode. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Conception, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is truly simple medical care that fosters a true partnership between myself and my patients that is built on a common trust, a mutual understanding and respect, and even spiritual faith. I am Dr. Althea Tyndall-Smith of Gainesville Direct Primary Care Physicians, and this is my DPC story.
Dr. Tyndall-Smith's desire to practice medicine started in early childhood, being profoundly influenced by her family doctor, who modeled success in long-lasting and trusting physician-patient relationships. Dr. Tyndall-Smith started her career in medicine in 2005 at York Hospital in York, Pennsylvania, after graduating from Drexel University College of Medicine in Philadelphia. It was in York she worked for a federally qualified health clinic, and she did medical volunteering for several programs there as well. For her volunteerism, she was awarded the Community Ambassador Apex Award by the Pennsylvania Association of Community Health Centers. She moved to Gainesville in 2013 from York, Pennsylvania, to be closer to family. After she moved to Gainesville, she joined the University of Florida as a clinical assistant professor in the Community Health and Family Medicine Department, where she taught medical students, saw patients at one of the outpatient clinics, and was part of the College of Medicine interview committee. She has always been interested in empowering patients to take control of their own health and understands the importance of teaching the patient to understand their medical condition to make the most informed medical decisions, something that takes time, which drove her to co-found Gainesville DPC Physicians. Dr. Tyndall-Smith enjoys her Caribbean culture through travel, food, and music. She enjoys sharing her joy of music by participating in the praise and worship team at the family church. She enjoys playing the piano and riding her bike, and shares her life and dreams with her husband and 2 sons. Together, she and Dr. Cotter opened Gainesville DPC Physicians in 2018. Welcome to the podcast, Dr. Tyndall-Smith.
Thank you for having me. I'm really excited about this. I've listened to a lot of your programs and I'm just, it's just a really good platform, I think, for us to hear other people's experiences.
Absolutely. And thank you for that feedback as well. I wanted to start by asking you, when you were in fee-for-service and considering direct primary care, how did you come to learn about the movement?
Well, I think, Marielle, I have to go back to my childhood. And I grew up in a country where there was a national healthcare scheme. Honestly, I don't know how our doctor was paid, but what I did know was that she was somebody who took care of my multi-generational family. She visited my grandmother at home. We went to her office, my siblings, my parents, myself, and she was just someone that was always a phone call away, would pop in and say hello. And she was someone who became a dear friend, a role model to us, and my total inspiration, for becoming what I am today. And so I have always envisioned medicine being practiced in a certain way, in that way, and just grinding through days of seeing more than 25 patients sometimes, no time for admin duties, just feeling like I'm running on a treadmill. I had to find another way, and something that I can do on my own terms. I have two boys. One was a preteen at the time, another younger. Mom was diagnosed with stage 4 cancer with many complications. And, after going back and forth from Florida to Maryland and then bringing her into my house and having to care for her while she was having cancer treatments, my life just became very inflexible. There was no leeway at work. Everything was just controlled by all of these things in my life. And I just got burnt out. I couldn't do it anymore. I valued family. I valued the time with my parents, but I had nothing, there was nothing that I could do to give myself that extra me time. I previously shied away from starting medical practice because of complications of insurance world, but then I'd heard of concierge care, but it still wasn't really what I wanted to do. It was not my way. And then I ended up talking to a friend and a fellow physician who told me about a simple concierge type practice that was run by a friend of a friend. I got her number, had an hour-long conversation with this doctor, Dr. Beth Renzulli, who's in Delaware. And she told me about her practice. She told me about her life in DPC, her personal life in DPC. And it sounded like a dream to me, really. I connected with Josh Ambert of Atlas MD, who also spent like over an hour on the phone with me, just answering all of my questions. He was laid over in some airport somewhere, but he offered to help me with anything that I needed. And he followed through with that. But DPC was simple, it was collegial, it was welcoming, and I was just completely hooked.
That's so wonderful to hear, Althea, that was your experience. It pains me hearing your personal story about how you were pulled in so many directions, especially with your mom's illness. As a person who took time off from medical school to help my father after he had his stroke, that hits home for me. Other doctors in DPC typically have a quote-unquote incident or a point that they've been pushed to leave the system. And although it is terrible that we have to be pushed to those points to sometimes decide that DPC is the right thing to do for us and our patients, I'm so glad that you made that jump and now you're beyond 2 years in your own DPC.
Yes, absolutely. It is. And I find that as I go to conferences and I meet people, there is a story. Everybody has something that has just kind of tipped them over into the DPC world if they had previously been in that fee-for-service world. And but it's the best thing that I've done.
On that note, I want to ask how, with you having found out about DPC the way you did, how did you and Dr. Cotter come together and join forces to found Gainesville DPC Physicians?
Well, we were both basically in the same place. We both were very delusioned with medicine, and she had actually already resigned from her position, and she had decided that she was going to quit medicine completely. until she heard about this Nuts and Bolts DPC conference that's in Orlando, just down the street from us. And she went to that, and she just absolutely rekindled her fire and her passion for medicine. We didn't know each other well. We both worked in the same hospital, same department. We saw each other in faculty meetings, had some conversations afterwards. We bonded about our same-aged preteen boys, and all of those inherent struggles, of aging parents and those struggles and the frustrations over how, we had to practice, and that the things that we felt were most important were never priority. And so I called her, one morning. We have a mutual friend that we both confided in. And this friend told me basically, oh, you should talk to Chenery. She is just, she wants to do her own thing. She doesn't know, So I called her that morning as I drove back from that faculty meeting. And we talked about, the what ifs. She talked about DPC. She talked about her conference experience. She asked me if I had a particular book. Now, I know you know this one, and he is on your podcast list. Doug Farrago, that official guide to starting a DPC practice that every DPC doctor had at that time. She was so pumped up. She dropped that book off to me on my desk that day. And this was sometime in February or March. I tendered my letter of resignation the beginning of May. We decided we were going to do that. We formed our LLC at the end of May. I resigned and had my last fee-for-service practice day on June 15th, and we opened our practice in September. It was, I guess you could say it was a whirlwind courtship. But we've grown together. We're very different. We're completely different backgrounds, but we shared a faith. We had strong Christian values, and we had that same desire to care for our patients. And, so we complement each other. She's like the big ideas, visions, dreams one. I'm the more detailed oriented, pull the reins back, let's work out the kinks of this person. And my husband has some tax legal experience. Her husband opened up a fee-for-service practice. So with all of that, we were able to just kind of work our way through a world that I guess, neither of us had any experience in, and no training. But it's gone well so far.
And it's gone well to the point that now it's not only yourself and Chenery, but now you've added also Dr. Emery. When did Dr. Emery come on to join you guys?
She came on about 20 months after we were in practice. And so she, as soon as we started our practice and just kind of experienced life that is DPC, we obviously wanted to share this with our friends and colleagues. We talked to some of them. We coaxed them into coming to conferences with us and things like that. But she was somebody that I had met many years ago at the university before she left and moved into private practice. And Chenery, my partner, she had more constant contact with her. And Michelle Emery, she was someone who longed for some things that DPC could give her, that she didn't have on a consistent basis in her practice. She left the university, she did some training in functional medicine, and so she had a practice that meant that she needed to spend more time with her patients. She needed to delve into their lives, their habits, something that is, really not sustainable in a regular practice. And, not to mention the frustrations of charting and all of those things that we all complain about. But it took convincing, going back and forth, trying to figure out how logistically she can do this. But I really want to do this. She came to the Nuts and Bolts conference with me in November of last year. And she got immersed in those amazing small group sessions. And she just, she knew that this was what she wanted to do. And not to mention that now her commute comes down from 2 hours both ways to 10 minutes. So It was a really good addition to our practice. I mean, she's a good fit. She's a woman of faith also. She brings that whole functional medicine side to our practice. And so just kind of helps to round, as we're trying to fill out our practice, she's added a unique part to that also.
When you mentioned the conferences, that's actually the last time that we saw each other in person was in Orlando at the last Nuts and Bolts. Anyone who's been to a DPC conference just gets a warm feeling in their heart. I hope that we can get back to those conferences in person as soon as possible.
Okay.
Earlier, you were talking about, and you made a very good point, the people who have these breaking points are typically people who have experienced the unpleasantness of fee-for-service. Have the three of you spoken with any doctors who have not yet been in fee-for-service and who are considering DPC?
Well, I actually just met a resident. He's a third-year family medicine resident. He's doing a rotation with a dermatologist who is very near proximity-wise to our office. And he came to our office for something, and we're very excited to be talking to him. He has been researching the DPC way of life, basically, for several years from the time that he started in residency. We did go to his residency program a year and a half ago and spoke. He was not there when we spoke, but it's something that he's very interested in doing, and he's going to come and talk to us and just kind of shadow us and see how we're doing things. So yeah, I mean, we have not had a ton of exposure to those folks, but I think that it's coming up more and more now that we are able to actually expose medical students, people even before medical school, to direct primary care. I think that that's going to become something that is much more common, just going straight from residency into the DPC practice.
When you mention that, and when you mention affecting the pipeline, essentially, of people who will become DPC doctors, it just makes me think about how you've really gone full circle. You've gone from watching your family physician to being somebody who is inspiring another person to potentially enter this world directly and to not have that abuse of the fee-for-service world. So that's incredible that you've come full circle in your own story. One of the things that you have said in the past is a quote that I love about your practice. You've said, "It will be a practice that will meet the medical needs of the patient in a way that is satisfying and fulfilling for both of us without the restrictions of the large institutions and insurance mandates. It will allow me to get to know my patients and to develop strong and lasting relationships, which is the foundation of exceptional healthcare." And you've touched on this already in this interview, but I wanted to ask specifically, what have you seen that mean for you and your patients since you've started?
Well, I mean, I see it in so many different ways. I mean, this means that I can provide care to those who thought they could not afford it. I have patients who neglect their own health because they have to choose between their health, because they equate their health care to insurance, and buying food. I take care of folks who have never taken ownership in their health. Now they have a chance, an opportunity to have a say and actually understand what is going on with their bodies and why they need to do certain things. I mean, I take care of entire families. I have a couple of multi-generational families, from the grandchildren to the grandparents, which is a beautiful thing. The funny thing is that we have patients who, they come to our office for, let's say, a well woman exam, and they're there, we're discussing everything, and they say, "Oh, by the way, I have this mole that has been bothering me, and I just really want to get rid of this, and what can I do?" And I said, "Can you refer me to a dermatologist or something?" And I was like, "Oh, where is it?" And then I say, "Okay, we can do it." That kind of service, that kind of accessibility, I think, is just something that you could not have in other ways. In essence, I have time, In my previous fee-for-service practice, a lot of times when I walked into somebody's room, my first words were, "Sorry, I'm late. Thank you for waiting. because I chose to spend that time with that patient. Even though I might have had maybe 10 minutes or 12 minutes allotted for that particular patient, I choose to spend the time that they need. And this is something that they can have in this practice, and that they see that. I mean, the other thing also is that in our practice, we all are women of faith. So when somebody comes into our space, we could be playing praise and worship music, and it is okay. If our patients want to pray, we're free to do that also, and it's okay. There's nobody looking over our shoulders like before. Some people wish to connect with us on that level. We're happy to do that because they understand that our interest lies in them and not in how much we will be reimbursed if we code their visit in a certain way. We are Christian women, women of faith. We have faith in God. We know that we're accountable to Him for what we do, but we're not exclusive. I mean, we have patients who are from all sorts of different backgrounds. I have Jewish patients, Hindu, Buddhist. I even have somebody who's atheist, who came into our space, and she was uncomfortable because we had a Christian counselor in the office, in the space that we share. But, she comes back because of the care that she receives from us. So our patients basically understand that who they see is who we are. And that's really important for us. And it's also important for them to know that they can be free to be whomever they are when they're in our space.
That's beautiful. And you were sharing a testament to how being able to spend that quality time with a patient, no matter who they are, really helps break those barriers of if someone is not of the same religion or the same ethnicity or the same gender, your healthcare goes beyond any of those
Correct.
Classifiers.
Absolutely.
Right?
When people come in, they need to be able to be who they are, say who they are, say what they need to say, and understand that whatever they say will be taken seriously. We don't have to rush them out of the room, so we can actually listen to what they say, put it into context of their lives. Culturally, they may see something a little bit differently or do something a little bit differently that may have an adverse outcome. We have time to understand our patients in that way, and then to advise them, to change certain things, do something, here's an alternative. That time is probably the most important thing that we can ever give a patient.
And I'm sure that goes beyond the office visit or the virtual visit, whatever the patient may have, in that you also have time to check up on them for progress.
Absolutely. And that's
the
the one thing that is not something that's easily done in a fee-for-service practice, at least in the large practices. Oftentimes I have to say that I cheat. So sometimes I would set an email to go out to the patient in advance. So send an email in 2 weeks so that you can follow up with them. But the fact is, though, that when they reach out to us, when we reach out to them, or if they reach out to us first, they know that we are accessible. And they know that I'm going to be the one who's reading that email right when I open it. And it doesn't have to pass through, a pool, a call center, a nurse pool, figure out which nurse is working with which doctor. And then I get the message maybe a day or two later. That doesn't happen in this kind of practice. So.
Multiple instances where the system has done patients wrong pop into my head. I had a patient who was experiencing rectal bleeding and sent a message to our portal. And that message did not pop into my box until 6 days later. So the idea that a patient has direct access to you as their doctor, and like you said, for a price that people can afford. I do think back to my time in Orlando. I was taking an Uber to Animal Kingdom and having a conversation with my Uber driver, and he just lost his job, which a lot of people are experiencing right now with the pandemic. He had 2 young kids under the age of 5 at home, and his daughter had asthma. And I wrote down, DPC Frontier. I told him about the mapper, and I said, this is a website where you can look into your area where you're located and find a doctor who is going to be able to take care of you and your family without putting you, at financial risk, because he was making a decent amount as an Uber driver, but just very, very worried because he didn't have health insurance for his daughter. So the fact you are providing that quality of care at an affordable price for anybody who needs a doctor who will make them feel welcome, whoever they are, is just a testament to how this is how we fix healthcare.
It's a movement and it's growing. It is growing, and we try to get as many people to join it as we can. But the way we do that is by having people see what good care, what great, fantastic care they can get in a direct primary care practice. We refer people to other areas. I have patients who are moving, and when they move, you mentioned that DPC Frontier Mapper. When they're moving, we look at that mapper and we look and see who is there. And have I met this person at a conference? I tell them, you look at these, see who is closest to you or who you feel you are interested in going to, and I will call them for you. And it is a community that is just kind of taking over, and it certainly fills a big void in the healthcare system in this country.
And I love that it's a lot easier these days to find doctors who are doing direct care or direct primary care. It's wonderful to see Absolutely. More dots on that map. And the other thing that I like to see is when a person cannot find somebody on the mapper, they drop a note on the Facebook DPC Docs group, or just a feeler out to somebody right. they might know in the area. And it is in that way that we promote this movement to grow.
Definitely
Absolutely.
Agree.
In your clinic, Althea, do you have just Jennifer Forrest as your RN, or do you also have, because you mentioned a Christian counselor, who do you have on staff with
on
you,
staff,
Michelle and
it's
Shenry?
Just Jennifer Forrest. We previously had a medical assistant that we started with. I mean, we started this whole movement with her. She came to Indianapolis for our first AFP DPC summit, and she was very pumped up about this, and we started it all. But it's just the 4 people. The 1 staff and the 3 physicians. We have other people now in our office. We had, from the beginning, a Christian counselor who has a specialization also in marriage counseling, marriage therapy, and family therapy. And he was somebody that we knew from outside. He went to my church. He was someone that my partner actually knew personally. And he just needed a space, and we had a room. So he came into our space. And so we have a great collaboration with him, because if we have somebody who needs to be seen, we can just go to his door and knock on it if he's available, and he can come in and introduce himself, and then they make that connection. He is entirely his own entity, but we just have a collaboration, a collaborative relationship. We moved last summer, just after we had Dr. Emery join us, into a bigger space. And we had another space that was potentially available, and a chiropractor came into our office. He wanted to see if he could have a space. And so we actually talked to him, and we convinced him to do direct chiropractic care. So I think he might be he's certainly the first direct chiropractic care clinic in Florida. But he is also his separate entity, and we also have a collaborative relationship with him. So he sees our patients. He has a membership just like we do, but he sees our patients at a reduced rate. So it works out really well. But then it's just the 3 of us in Gainesville, DPC physicians, with our now RN nurse that we just hired in August of this year.
That said, does Jennifer do front office duties as well as RN duties?
So when we started, we had an MA, very excited about it, but she had no admin experience. But when you're starting a clinic from having 0 patients, essentially, I mean, I think we started with 40 people pre-enrolled, but when you're dealing with that little amount of patients and not having to do all of the other admin stuff that's associated with other clinics, other types of practices, it was fairly easy. As the patients started to build, then obviously the workload became a little bit more, and having to coordinate things and making sure you have solid systems and procedures to do things became a little bit more of an issue, I think. And she was just really she wanted to do stuff. She liked to have her hands in there. So we decided we got her a job doing what she wanted to do in a different practice. And we just kind of waited for someone to fall into our laps. Basically, we didn't want to go to Indeed. We didn't want to wade through a whole bunch of resumes. We just sent it out, word of mouth. We're looking for somebody. And Jennifer came to our office for an interview, and she was trying to get out of her job in rehab medicine, and she just fit in. You know, she was somebody, again, of great Christian faith. You know, she was so enthusiastic. I mean, who applies for a job, gets a job, then says, well, I can come in these 2 afternoons a week because I'm free, just to kind of see how things are going. I can help you out. I know that you have nobody and you all are going a little crazy here. And she just came and she volunteered her services, you know, for a couple of days before she actually became on staff and salaried. So she fell into our laps. We had this little joke, Emery and I, we said, when Jen comes in, we had a note that said, Jen will fix this. Any problem that we had, Jen will fix this. And she's been doing a pretty good job of it so far.
When you share that, it makes me laugh because I think of the easy button that Staples uses for its commercials.
That. I mean, you know, actually the other thing about Jen, when she applied, is that we, like some DPC practices, we have a pharmacy. So we have a dispensing pharmacy in our practice. And so we have to, in addition to managing patient care and the administrative stuff, you have to be able to also administer the pharmacy, which is something that obviously just fell into our lap. So we did everything. And Jen's resume came with pharmacy tech. And we were just like, oh my gosh, this is absolutely amazing, you know? So she had all of those things that we needed. So yeah, she's working out really great.
When you guys were looking to hire, how did you go about advertising the position? And the second question is, does Jen have benefits under your practice?
We didn't really advertise. We thought about it. We were going to put something on Facebook. There's a word of mouth for Gainesville. We do a radio. We are sponsor on a radio station, a Christian radio station, and we thought maybe we can put an ad through them. But when we decided that we wanted to make sure that we got the right person, and we have gotten so many good patients just from word of mouth, that's what we kind of relied on. And we figured, you know, we will be sent somebody, basically. And we got a couple of referrals, and she was one of them that was referred by someone that actually both Emery and I knew. And she came very highly recommended, and it seemed like it was just the perfect place. You know, she was at the perfect place at the right time, and we were able to hire her. We hired her, and the benefits that we have, and we're still working this out. She knew when coming in that it was not like the full-on benefits package that she would get as if she's working at the university hospital where she was working. But I find that people who are so they are so invested in the idea of how we take care of patients that there are certain things that they are willing to delay. And that's one of those things that she was. But we've told her that we can give her some type of money for medical coverage or sharing. We actually were talking about the member cost sharing ministries, and she was interested in that, the Christian healthcare ministries. And also we were looking into Sedera, which is another one which we can actually use for our whole practice. So that is something that we have given to her as an option. And then also talking to her about retirement and so on. And that's something that is in development in our practice. It's just been Emery and myself. We have Michelle, who's come on. She came on as really a contracted physician, but then changing into an employee. So now that we're really going to be having a solid base of employees, we're going to be making that the next thing that we have to do.
Althea, I wanted to ask, can you share with the listeners a little bit about the patients who make up your population at your practice?
A pretty diverse group of patients. It's interesting because when preparing for this interview, I thought, I should probably look at some of these numbers because I don't generally do that a whole lot. And it was interesting to know, I thought that we had more women than we did, but we have about 58% of our population are women, 42% are men. And in terms of ages, the bulk of our patients, about 75% of them are between 19 and 64, but we have about 20% who are children. I think our youngest patient, my patient, is just going to be 1 year old. So it's quite a diverse, and then about 5% of our patients are Medicare age population. We have employer groups that we take care of, companies, and about a third of our patient population is through the company. Those can be, the adults as well as their families, because we take care of the employees themselves as well as their families. And then in terms of those who have insurance and who don't, we have about a third of our patients, again, have some type of commercial insurance. And then we have some that have some type of a cost-sharing plan. I don't think that we have that well documented in our system, but I know that we have more than we have listed. But as you know, for direct primary care, we don't need to use insurance, but I think more and more patients are realizing that even if they have insurance, the benefits that they get from DPC outweighs the fact that they have to pay a certain monthly fee. And oftentimes these folks will change their insurance plans and change it to a very high deductible type plan. So we have all sorts of those. And then in terms of people of ethnic origins, we have a good variety. And, people, foreign patients, I've got 2 families that are from China that don't speak any English, and it's just seems like a very multicultural. We're still trying to diversify a little bit more, because I think one thing about DPC is understanding how it works and understanding that it's not too good to be true. And people are accustomed to things a certain way, and it requires a lot of education and a lot of immersion, just hearing about it over and over again before a lot of people will take that leap into becoming a member in a DPC practice. So it's a work in progress. We try to get into the communities, especially the local Gainesville community. I'm trying to do that through organizations that I'm part of, like the Chamber of Commerce. There's a Gainesville Black Professionals organization that I'm also a member of, trying to just bring that population into the DPC world. So, there's a lot of education to be done in this, in this movement that we have.
When you mentioned your patients who have come from China and who do not speak English, how do you communicate with them? I use
the translator on my phone a lot, but they also have a relative who speaks English. And so a lot of times we will use them as a translator, and then we use other technological resources. I have a family from China, I have a family from India, and then there are a lot of Spanish-speaking patients. I can very rudimentarily get through a little bit of a conversation because I understand some Spanish. I cannot really speak it, but Dr. Emery actually in our office, she speaks Spanish. She spends a lot of time in Central America. And so we have resources in-house too that we can use for translating purposes.
If you wouldn't mind mentioning, what is the tech that you use for translation? That's great to hear a DPC doctor using Google Translate. I definitely like listeners to hear somebody speak of that service, just because typically DPC doctors are looking for ways to cut down cost while still maintaining quality. And that is an app that is very accessible to everybody. So thank you for sharing that. The time of year that we're doing this interview, it's the season of open enrollment. So given that you've experienced patients who have chosen those high deductibles and have chosen health care versus health insurance, have you guys actively gone out and sought ads on the radio platform that you use or any means to increase membership during open enrollment?
Not. And when we opened, the first year that we opened, we felt like that was something that we needed to do. But I think that every direct primary care practice needs to figure out what their goals are. Who are they targeting? How do they want that patient flow to be? And so being a two-physician practice and basically telling folks what we tell them that we will do, we have to be able to deliver what we promise. And if I promise you that I will be able to pick up the phone and talk to you when you need me to talk to you, or I will be able to respond to your emails and your texts and things like that and not be overwhelmed with a whole lot of patients, then I need to be able to do that. And we sat back and thought about it. And if you go and you do a big push, and if you go out and you're just scrambling for patients, then you'll just get a whole bunch of them that you'll have to onboard, which is a tedious task. And then you end up with a lot of new patients all at the same time, and it is hard to give them good service. So through these months, we have been growing pretty steadily, and it's at a good rate, and a rate that is good for the growth of our practice and for us being able to take care of our patients the way that we want to. And so the way in which we do it is that we just talk to businesses. I mentioned that I was part of the chamber, the Gainesville chamber. My partner is a member of BNI group, which is much more intensive in terms of networking and the being exposed to different businesses and having the businesses having to refer to you. So we have a really good base through that, and we go to our businesses. And so what we've done is we've presented to our businesses, this is the time for open enrollment. This is, to these new businesses, this is what we can offer you. We can offer you open enrollment, you get insurance, but your employees still have to go out and find a doctor. They still have to deal with the waits for a visit. They still have to deal with being able to access the physician when they need to. What we can offer you, if you make this kind of change to your insurance plan, or consider one of these cost-sharing programs like Sedera, for instance, we can give you patient care. We can give you a doctor's cell phone number. We will be able to take care of your patients, your employees, keep them healthy, keep them on the job, make your work, your life much better in terms of productivity for the business. And so that's kind of what we have done during that open enrollment season. So we don't have droves of people coming in, which is okay. But we are still out there and people are hearing about us. And then through word of mouth from those employees and their family members who tell their family members, then we do get some trickle down in terms of DPC interest and enrollment.
And recently with the pandemic, have you turned discussion with employers into something virtual, or do you still go? Are you still able to go in person?
We did one meeting in person a couple of weeks ago. And we did that because this employee group, the owners really wanted their employees to be accountable. They felt that it was important for them to actually see who we were and to be able to, just kind of experience who we were and to see where we did what we did. So obviously taking all of the proper precautions, we put on our N95 masks and so on, and we went in and we gave them a presentation, and then we brought them back to our office, and individually they just kind of walked around in the office to see where we were. That's a big barrier for a lot of people not going to the doctor. Well, I didn't know where you were, or I didn't know how long it would take to get there. I had no time. So if somebody knows where we are, they see our nurse Jen's face at the reception area. They know what she looks like. They see all of the other people within the office. they know and they feel comfortable. So these employers wanted them to take ownership of their health and wanted to hold them accountable from an employee standpoint to use our services. And so we decided that we would make an exception for that. But a lot of these meetings we can do virtually with our groups. We had a meeting with a church just last week, and we did that completely virtually. So the pandemic has, it is obviously, and it's so much better to meet people in person, to be able to see them share the space. And it's just a completely different vibe, but we must do what we have to do. But we still want to get face front with them. So if it's face front via the computer, that's better than nothing.
Yeah, I agree completely. And, like you said, the business and the patient population has been growing steadily despite the pandemic. When you give a presentation, what are the main bullets that you focus on?
Why DPC is such a good choice for them to understand that accessibility truly is that. We have this thing where my husband, when we were setting up our practice, would say 24/7 accessibility. Are you sure you really want to say that? We are accessible, but we don't expect that people will be calling us at midnight for things that are not urgent. And that's one of the things that I think that we train our patients to do. You can access us anytime. We will answer your email at 7 a.m, so you don't have to call me when you think about this thing.
I have become a huge fan of podcasts. Ever since Sarah Koenig hosted the first season of Serial, I was hooked. Now, creating this podcast has become part of my daily life. While it is an exciting new hobby, I also see it as a privilege that I get to interview so many DPC and direct care doctors. If you are interested in starting a podcast, let me tell you a little bit about Anchor. First of all, it's free. There are creation tools that allow you to record and edit your podcast right from your phone or computer. Anchor will distribute your podcast for you so it can be heard on Spotify, Apple Podcasts, and many more. You can make money from your podcast as well with no minimum listenership. It's basically everything you need to make a podcast all in one place. Download the free Anchor app or go to anchor.fm to get started.
Some people like PowerPoint presentations, and we have something that we show to them. We have, I think the biggest things that impact people are real life examples. Somebody comes into our office having a certain experience, and then we give them a completely different experience that either is something that is meaningful to them in terms of their mental or psychological well-being, not to mention, of course, their medical well-being, but also financially. For instance, I oftentimes refer to a patient who came to me. They pondered for about 4 or 5 months. They came and had a meet and greet. This was before the days of COVID. I talked to them. They loved the practice. Their granddaughter was my patient, and the big thing for them is that he was somebody who used 3 of the television meds. Those meds you find on television often are like between $200, $100 and something, $300 easily a month. And he used 3 of those. And he was paying out the nose for those things, even though he had Medicare coverage. And so he showed me his explanation of benefits. And in the year prior to starting with us, which was 2019, he spent $9,000 out of pocket for his medications. And so when you show somebody, why did he spend this money? How much was he paying? Something like atorvastatin, and these numbers aren't, I can't remember exactly, but atorvastatin, he was paying for a 30-day supply, he was paying something like $40. And in our clinic, I can get him atorvastatin for 90 days for $8 and something cents. when you put those two things together, I mean, we did pharmaceutical programs for the meds that he could not afford. And 2 of the 3, we were able to get him, because he was on a fixed income. He was Medicare. 2 of the 3 were covered. He got those meds for free, sent to his house. One of them he ended up having to pay for. I would get occasional samples. I will give him samples. And so he cut his cost for that one med. And all of the other stuff that he was going to the pharmacy for, getting these monthly scripts, for the entire year of 2019, he paid $98 out of our pharmacy. Can you imagine that? So we would show that, those kinds of stories. Somebody goes in for an x-ray in the emergency room, think they broke something, but we have our x-ray that can cost $40-something. They paid over $400 for their visit. When people see that, and then they see that they also get me or my partner or Dr. Emery to actually talk to them and follow up with them, I mean, it seems almost too good to be true, but but that is one of the things, those are one of the things I think that's very important for them to understand the benefits of DPC.
I am grateful that you mentioned those personal experiences and the personal stories that your patients have had. I just had our explanation of benefits come out from having our baby in November. And in California, with Blue Cross PPO, our explanation of benefits said our overall cost of having a baby in California, having stayed 2 days in postpartum, having a C-section, was over $82,000. And my bill that we paid with our HSA was over $2,000. And so, when a person gets that data presented to their face in colors, pie charts, graphs, whatever you have it, as well as hearing a doctor tell about those costs, I think it really hits home for people because either everyone has had an experience of these astronomical bills that come from our healthcare system, the insurance-driven form of it, or they know someone who's been affected. I know a young person who received a $6,000 bill from the emergency room where literally he was given a paper bag to calm himself down after a panic attack. So those examples, they exist.
It's amazing how, and most people have no idea how inflated the costs are. And that's one thing that we learned so much about coming out of fee-for-service from a big practice where we are just told what to do. For instance, for cerumen impaction, irrigation of the ear, if we do that, if somebody comes in and they're having ear pain or something and I try to take a curette and I can't get it out, so I have to call my nurse to flush the ear out. Do you know how much money that costs?
Here the recording got cut off, but what Dr. Tyndall-Smith is explaining is that her partner, Dr. Cotter, had a patient who, after receiving cerumen impaction treatment, received an explanation of benefits from his insurance company.
$800? So when we started up our practice and we were buying stuff, you need that it's a spray thing. We call it elephant ears. I think I got it from Amazon for $40-something. You have to get the little small catheters, the spray tips to go inside the ear. That may have been another $20 or something for a big box. You need water. You need some hydrogen peroxide. You can get that from the dollar store. And you need 5 minutes to flush that ear out. But when things are run through insurance, they get inflated, then they get discounted, and then, you don't know what you're paying. Now, the person did not pay that much. It's what was shown in the explanation of benefits. And then they end up paying, something like $100 and something for that. But it doesn't have to cost that much, right? What is going on back there that inflates the cost so much? And when they can just do it in our DPC practice basically for free. It's a justice issue, really. We are told the insurance companies make us code. We have to code for cerumen impaction. That was not the main part of my visit, but because I wrote it in my note and then you're going over and looking at it, you have to code for this. You have to make sure you put the code for it. And then you put the code in and that is what comes out. It's just ridiculous.
I'm sitting here shaking my head because, like you say, it is a justice issue that as a country, as a culture, this is accepted. by most people. And, we are doing what we can to get the word out to change that. But oh my goodness, $800, that's just ridiculous. I mean, I prefer using the Bionics tool, the lighted ear curette, and an alligator forceps that you can, autoclave forever if it's a good tool. But I'm thinking here, what can I buy with $800? I mean, that's a lot of money. When you are talking about people choosing food over healthcare, that is unacceptable. And again, it goes back to the power of people getting it in their face. This is what you are providing at an affordable and at an honest rate. The idea that you can provide 3 months of medication for under $10, that is definitely something that, when doctors can self-dispense and when they choose to self-dispense, it's a huge point of value for practices. I want to touch on pricing in your practice in a little bit more detail. One of the pricing points that you have for patients is listed as a church ministry rate of $35 a month. Can you share a little bit more about what that means to have a church ministry rate in your practice?
The ministry aspect of the practice started out with my partner, who came up with a WholyWell. WholyWell was something that she had started up. And the reason why she did was because the pastoral care, people who go in, who have these pastoral roles, have very special health needs. A lot of times they can't divide the physical from the spiritual when they're battling something. Pastors, they've made this pledge of accountability to God often, and they have to bear this tremendous burden. And a lot of times they get attacked by the enemy. And my partner, she had a personal experience with healing, with actual spiritual healing. And so it's something that she is very strongly invested into. A pastor may need more than just being able to prescribe medicine and talk about this problem. Sometimes they also need somebody to be prayerful with them and for them, for their wisdom, for their discernment, keeping them from being sick. But it's something that is very important in terms of their complete health. And so we thought that was important for those individuals. And so the $35 is for pastors, people who are in full-time ministry, and we take care of them, but then we take care of their spouses and their employees and so on, and we can treat that kind of as a company. So we have the company prices and the other regular prices that go along with that, but that $35 a month is for our ministers as part of our ministry, the ministry part of our practice, what we can give back to the community. And, through that, we're able to also reach people who probably do not have the medical care available. A lot of Christian people in the churches. And, if your pastor trusts somebody, then somebody is apt to trust that person also. And, so it's something that we feel that we need to give back. And that's part of our giving. Ideally, what we'd like to do is to eventually form a nonprofit part of our practice so that we can do things for people that we want to do that will not require them to necessarily have to pay for it. Being able to give people what they need and what they deserve. And so that's one of the things that we are thinking about in the future.
I think that really fits with the fact that you three have a Christian base. One of my mentors and one of my former attendings works in Modesto at St. Luke's Family Practice, and they have a population of patients who pay an annual fee, and that annual fee allows them to do their own scheduling, have longer appointments when needed, have first dibs at appointments. But the money that is generated from that patient population allows an open door policy for patients who don't pay anything and literally get the same quality care. But that's a certain form of DPC that they've chosen to do. And everybody has their own way of providing care. And that includes providing care to people who it can potentially create a financial burden for. One of the features on your website is a list of partners and friends. Can you share what does it mean to be a partner and friend?
you trust us to take care of your people, your employees. We will try to take care of your business. So we create direct links to all of these places. We promote their businesses. If they are a medical, we have doctors' offices, physical therapy, that kind of thing, then they're a referral base. We'll send our patients to them, and we know that our patients will get good service, and a lot of times they have certain discount or particular arrangement that's worked out. If you're not health related, that's where we just refer people. In our practice, we get into conversations all the time with people, and they're talking about, oh my gosh, my electricity went out in this part of the house and it's such a problem, and I'm trying to find somebody. I was like, oh, I know I know some people who can do that. And so a lot of times we are able to provide references for a lot of these folks. And, so these businesses, some of them are those who have their patients in our practice. Some of them don't have patients in our practice, but like medical offices and so forth, that they feel very strongly about DPC and are giving our patients access or services. It may not necessarily be that they have a discount when they go to them for a consult, but it definitely is that I can get one of those doctors on the phone, and I have some abnormal lab work, and I have a doctor who I can just call on my phone. I can send just a screenshot of just the lab work, and I can say, this is a hematologist that we deal with, and I'd say, this person has this, I think that this is an issue. Should I get this additional blood work, or do you think this patient just needs to be referred? And so we are able to have those kinds of conversations with our patients, oftentimes saving them money, being able to do more of a workup for them to figure out indeed what is going on. It's kind of a validation of our care, somewhat. And so these friends and partners are people who are invested in DPC in our practice in some way or the other. And in return, we try to promote them, refer to them, and give them just the general advertising from you just looking, people just come and randomly find things, and that's also helpful for them.
And it's definitely a way of promoting
Absolutely.
Your local community, but also extending the community spirit of DPC. Althea, I want to ask, in terms of practice management, looking back now that you guys have passed your 2-year anniversary, and that's so exciting, can you give us some examples of where you might have changed your practice?
Having somebody who has more experience and the ability to do more in terms of the supportive role. When you're running a DPC practice, which is primarily responsible, you're primarily concerned with patient care, but there's so many things that have to be done, that you have to remember to do, that you have to figure out how to do. And it's such a time saver if you have somebody who is organized, who is forward thinking, who is a problem solver, and who has all of those skills to do many of those things. And so for sure, getting somebody who is able to do that has helped us to kind of streamline. It's still a work in process. It probably will be always a work in process, but that is something that I probably would have done very early on, and I think that would have been a benefit. The other thing, getting a bookkeeper. Everybody, we just studied medicine. I was nothing in finance. I was nothing in advertising, sales, marketing, none of that stuff. I learned QuickBooks online. You can go and do tutorials on it. You can figure out how to do the basic stuff, but it's a time eater. And oftentimes what ends up happening is that you defer from that and go and take care of your patients. And then you come back and then you've got a bigger time eater on your hands as you try to figure out what needs to be done. So we've gotten a bookkeeper, and that has helped tremendously.
On that note, what do you see in the future for Gainesville DPC physicians?
Shenry and I have done a presentation, and we've done presentations, and at the end of one of these presentations, we had a picture of Megamind. Remember Megamind? Right? We're going to take over the world kind of thing. But seriously, we're working to create an environment that completely cares for our patients, right? Physically, medically, psychologically, spiritually even. We opened up in 2018. I told you we got the Christian counselor. We just moved. We pulled in the chiropractic care. He has, he does functional movement screening and therapeutic taping. So helping that aspect, that facet of people. But our big vision is forming a multi-specialty DPC group. Add 3 to 5 primary care physicians, adding a specialist. That's something that we look forward to. For a small DPC practice, trying to keep overhead low as possible and trying to increase our value, doing advanced medical procedures. My partner has done training in vasectomies. We can do those. We generally do colposcopies and endometrial biopsies, those kinds of things. But for smaller practices, this could be very expensive, especially in terms of malpractice insurance. So another big dream is just having a DPC procedure clinic in Gainesville. There are a lot of people, a lot of practices, and a lot of the local DPC clinics that do not have people who are trained in that. So if we could be a cash pay referral base for all of these practices in the community, to send them for those vasectomies, for the infant circumcisions that are not done in the hospital when patients are born, endometrial biopsies, colposcopies, joint injections, all of these things to be able to take care of our patients. I think that's one of the things that we are going towards. That's a definite goal for us. And then just having an employer plan. DPC is generally a reactive type of practice. We're here for you when you need us. But maybe changing that up a little bit and working with employer groups and being more proactive. I mentioned before, one of our goals is to make their employees more healthy, make them responsible for their care, make them, much more productive because they're not neglecting their care. Then they spend so many days out of work. They have to go to a doctor's office and sit for 2 hours before they're seen. So their whole afternoon is gone. They have that accessibility. We go in there and we talk to them about things that need to be done. We make sure that their blood pressure is checked. We make sure that these things are done, and just being more proactive. We're in the process of setting up a program like that. And that's another thing that we're looking forward to. But I think that our big pipe dream is just kind of getting that multi-specialty DPC group, getting more of our physician colleagues interested in DPC, and just spreading the word through our students.
Previously, you were a clinical assistant professor and teacher at the University of Florida in the Community Health and Family Medicine Department. You were also involved in the interview process for prospective medical students. Can you give any insights about how we might affect those in the pipeline to encourage trainees to choose family medicine and DPC? You touched on this earlier with the one man who is considering DPC, but when others are speaking to medical students or people interested, how would you affect the pipeline?
Yeah, absolutely. I think that, this is an exciting time for people who are interested in going into medicine. Young medical students, first-year medical students, even pre-med students. And I think that we have the ability to influence them through immersion. So even though we are not clinical staff, clinical teaching faculty at the university, we are still able to have students in our offices for preceptorship. So for instance, just last week, we finished a 2-week session with first-year medical students, and we had 4 students coming in for 2-week sessions, but this is the time when they are learning how to speak to patients, how to interview patients. What a better place to learn this kind of skill, right? In a DPC practice. We've had 4th-year students who are interns doing their electives come through our office also, just learning about DPC, learning about another way, a better way that they can practice medicine. We have to put ourselves out there. As I said before, we went and we were able to speak to a residency program. We spoke at a primary care innovations conference at the University of Florida last year, where people, we were just explaining and exposing people to direct primary care, how it works, the benefits of it, and just, I think, getting that information out there is very important so that people can make those types of informed decisions. pre-med students who have come through. We have one who came in and she was supposed to be done at Thanksgiving. She just wanted to shadow. She needed some experience. She's applying to med school, but she fell in love with DPC and she loves our practice. So she's going to come back and volunteer, And so I think that is really the way in which we get to them is from the beginning. It's like we say that we have to start our children out. The foundation that we lay for them is important. The foundation that these pre-med students and these early med students have is also absolutely important. And if we are able to affect that, affect some kind of change in them and their thinking at that point, then, we have done our job.
A couple of things come to my mind when you share what you just did. One of those is that's the reason why I chose rural family medicine, is because where I trained in Superior, Nebraska, a town of 2,000 people, I saw an incredible form of family medicine. And yes, it was fee for service, but at the same time, it was where the family medicine doctor was all there was in terms of doctors in the town. And there are 3 family doctors in Superior, but they do everything. C-sections, they do thoracentesis, paracentesis, vasectomy, similar to how you're talking about doing a DPC procedure clinic. These doctors were the main spark for me to pursue an unopposed family medicine residency. And that's the other thing that comes to mind, is the idea of an opposed versus an unopposed family medicine residency. That was something that I did not know about until probably late in my family medicine rotation, the idea that there are opposed programs out there. And for those people who might be medical students listening, who might be in their first or second year, an opposed medical residency, a family medicine residency, is one in which there are other specialty programs within the hospital. And so when I was in my training, and probably a lot of people can relate to this, I had 1 month in an opposed program at Creighton. The hospital actually doesn't exist anymore, and 1 month in Superior, Nebraska. And so when I was in Superior, I think I delivered 6 or 7 babies in my time in Superior, and in my time in the city in Omaha in an opposed family medicine program, I was on standby for 1 delivery during the entire month, and I never actually got to do really any procedures. And so it is so true about getting people exposure early. I mean, you talk to surgeons, you talk to people who do emergency medicine. There's usually a story, similar to how, people choose DPC. There's usually a story about, I saw this in medical school, or I saw this in residency, and this is what made me join this specialty. Yeah. But for family medicine, I think that I can just picture it, a medical student going into your clinic and seeing you spend 40 minutes, an hour with a patient, learning about them, talking with them getting to know you and feeling comfortable with you, and then jumping into a 12-minute visit for a fee-for-service patient who might be a new patient, that you can't undo what you've seen in DPC. So that is wonderful that you've been able to have people who are early on in their medical careers come see what you do.
I think that's important. The influence is very important, because a lot of people don't know. And when they realize what they can do, what changes they can effect, I think that, this becomes real and a better chance for us to grow our community.
You have already mentioned using Google Translator, having your Christian counselor available, having the direct chiropractor available. In addition to bringing value through those avenues, are there any other tech or tools that you use and love in your practice?
We have ultrasound in our office, but it's not something that is used very much. We need to get a better machine, but that is something definitely that is techie that I would be very happy to have at my disposal. But I don't really have that many. I think there are these very neat EKG machines that you can just use with your fingers and then an iPhone. And I don't have that because we were gifted an EKG machine, like a real one, so which I love, and that the ability to do those things. But no, that's basically it.
For those folks who might be entering the DPC space now or in the future, what advice could you give?
That it can be done, and they need to trust that it can be done. They need to plan. Some people say yes, some people say no. I mean, there are people that I've met who have planned for 2 years to do this. We planned for a couple of months and ran into this. I think that they need to have a solid plan. They need to know what their goals are. In terms of their DPC practices, you can make it whatever you want it to be. You have to match it to your life and make sure that it works with your life. Because most people who come out of fee-for-service come out because they're not happy with their life. They're happy with medicine, but it's just not how they practice medicine. And so I think that is the major thing for them to develop something that they know can be sustainable in their lives. Not something that Josh Ambert did in Kansas City, or that Lee Gross did down, in Florida, or, even what we did here in Gainesville, but something that you need to make your own.
Whether you're a micro practice or whether you're in a practice with partners, your patients are going to know you as a practitioner on a very personal level. So I think that's so important for people to hear. Are there any resources that you specifically recommend?
The DPC Docs website, which was mentioned here before, I mean, it's an amazing resource. The community is so open to sharing their knowledge, their advice, their resources. People share agreements, they share forms. We don't have to reinvent the wheel. And so the DPC Docs website is a really good resource. And then also just learning about things that you're interested in, finding courses. So for instance, the POCUS, the point of care ultrasound course that we took together in California, finding opportunities like that, so that you can increase your skill, so that you can increase or work on increasing your value. I think that is of greatest benefit. So that's another resource. But DPC Docs website, we can find anything out from that. I love that group.
On that note, just because you and I have experienced the quality of the Global Ultrasound Institute, I want to put a plug in for people who might not be aware, who are interested in POCUS. There is a Global Ultrasound Institute DPC POCUS Fellowship. For further information on the POCUS DPC Fellowship, email globalultrasoundinstitute@gmail.com and mention that you heard about the program on the podcast. If there are medical students or other doctors who are inspired by your story and who may want to reach out to you, what is the best way for them to do that?
They can reach out to me through my email or just going directly to our website. Our website is GainesvilleDPCMD.com. My email address is a little bit longer, but it is Tyndall-Smith, MD, at GainesvilleDPCMD.com. And they can reach out directly to me, and I would love to share more of my story and to help them in their journey.
Thank you so much, Dr. Tyndall-Smith, for joining us today.
It was my pleasure. I love talking with you. It was such a great conversation, and I look forward to hearing stories of all of those other interesting DPC docs that we have out there.
Next week, look forward to hearing from Dr. Drupad Joshi of We Care Neurology. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Until next week, this is Marielle Conception.